Okay, so thank you for coming to our panel session, everyone on Zoom. My name is Jasmine, and I'll be the host for tonight, and Harold will be your Zoom host. Okay. So I wanted to go ahead and give a little bit about our mission as DHI. So we are here to support the growth of health professionals within the USC School of Pharmacy and Health Science Campus within the fields of digital health and informatics. We hope to advocate for the advancement of digital health in an equitable manner so that historically marginalized communities are able to participate in a growing area of health. We also aim to create a sustainable organization that allows students to build the practical skills needed to enter careers in digital health and informatics. So students get to build these skills through our mentorship programs, project development management, and our interprofessional collaborations. So we want to increase the access to digital health and literacy. Next up, I wanted to introduce our faculty advisor. I have the pleasure of introducing Dr. Carrie Franson, who is the Associate Dean of Academic Student Affairs at the USC School of Pharmacy. So Dr. Franson is an educator with more than 30 years of experience in health professions, educational programs around the world with expertise in interprofessional practice, education, curriculum development, and healthcare workforce development in both the United States and abroad. So please welcome Dr. Franson with me.
Thank you so much. And what a pleasure it is to be here. Hello, everybody who is out in the, ether, watching on Zoom. It's really my pleasure to work with this incredible organization that is quite new to our University of Southern California campus. It's amazing to me whenever a student comes forth and says, I've got an idea. How can you help me? And my answer, whenever I hear that, I get so excited. I always say, any way you want me to, because the idea that these students who bring forth this particular project to you, that they are motivated to make sure that everybody is exposed and has a good understanding of what digital health is, how informatics help health for everybody, and with the idea that this needs to lead to a more equitable healthcare system, I think are all just amazing aspects of their mission that just really made me want to step up and say, yes, I'll be your advisor. So the incredible group of and talented students who are here today. We have Tang Moa, Catherine Perkins, Louis Larios, Evans Pope, and of course our hosts, Jasmine Hanna and Harold Wen, who really have done a tremendous job of reaching out to just fantastic pharmacy professionals who are doing the good work in digital health and informatics. To the fact that they're willing to come here, we thank you, to share your expertise and to just provide everybody who's in this room. And by the way, everybody who's in TV land, there's lots of people in this room today. So this is an ever growing and popular area. And so this is a testament to you all as pioneers, as being in an area and already developing expertise where, these young people are anxious to follow in your footsteps. So we thank you for your efforts to be here today. We very much appreciate it. And now I'm going to turn it over to Tang Moa so she can continue on with the program. And thank you again.
Thank you, Dr. Franson. Dr. Franson has been one of our greatest champions from day one. And I want to thank everyone tonight for setting aside time to meet for our first informatics panel session. It feels like it was just yesterday where this was just a vision. My P1 year, the 2020, the height of the pandemic. Some of the people up here today I had calls with as a P1 asking them about how to build this organization and what would go into it. And yet here we are today, bringing together professionals and students together, also that we can learn more about technology, digital health, informatics, and how that improves health systems. So we're incredibly excited to have pharmacy students from across the nation, actually. We have Zoom participants throughout the United States tuning in today, and then we also have the USC School of Pharmacy here today. And it's kind of been a pleasure just to see what's had to come to get to this point. So thank you to the faculty, the staff, the e-board members who are here tonight who have worked really, really hard just to get us to this point as a new organization that just launched this fall officially. Most importantly, our organization has really been supported by professionals and supporters in the field. So everyone up here today, some of you I just met hardly this summer, a couple weeks ago. And the amount of support that we have received locally at the state level and even at the national level has been and very encouraging for us as students to want to learn more about this field and to stay passionate in it. So thank you. Thank everyone. Tonight we have a lot of exams this week, so if we can just give everyone in this room a round of applause for being here. Oh, that's me when I had black hair. So I'm incredibly excited to introduce the panel today. And the first panelist I am introducing is a fierce advocate and professor at the USC School of Pharmacy. His name is Dr. Scott Mosley. You can go ahead and stand. Dr. Mosley is an assistant professor of clinical pharmacy in the Titus Family Department of Clinical Pharmacy. His research is focused on pharmacogenomics, which incorporates genetic information with other clinical factors to optimize drug selection. He received his pharmacy degree from the University of Texas, where he worked for a little bit afterwards at MD Anderson Cancer Center. He completed his postdoctoral research fellowship at the University of Florida College of Pharmacy in the Center for Pharmacogenomics. And during that time, Dr. Mosley carried out a research protocol to assess the value utilizing CYP2D6 genotype to guide opioid selection for patients with cancer. The next speaker is Dr. Benjamin Ariel. I was introduced to Dr. Benjamin Ariel after completing a graveyard summer rotation at Cedars-Sinai this summer. And I reached out to him this summer and he graciously agreed to be present today. And Dr. Ariel completed his pharmacy school at the VCU School of Pharmacy in Richmond, Virginia. He then completed a PGY1, PGY2 residency in health system pharmacy administration with a focus on medication health pharmacy and operations at the Johns Hopkins Hospital in Baltimore. And after residency, he shifted into informatics and became the pharmacy informatics manager at Cedars-Sinai Medical Center, where he's been for the past 4 years. So join me in welcoming Dr. Ariel. So I had the privilege of being introduced to Dr. Adrian Meadow through a former USC graduate and actually a former CHLA intern, as well as Catherine Perkins, who's one of our co-founders. And Dr. Adrian Meadow received her Doctor of Pharmacy degree from UC San Francisco, where she then completed a PGY1 in her general residency at the University of Arizona, Tucson. Her current role is as a pharmacy informatics specialist at Children's Hospital, Los Angeles. Her responsibilities include design configuration of the EMR as it relates to the medication process. She serves as a primary informatics preceptors for API students and PGY1 pharmacy residents. And on her spare time, she cycles, jigsaws, puzzles, and does movie trivia. Let's give a warm welcome. I had the privilege of being introduced to Dr. Balsam this summer. Dr. Jeffrey Balsam was introduced through Dr. Carrie Franson, our faculty advisor. Dr. Balsam is the VISN 21 Clinical Informatics Program Manager, where he's responsible for development, oversight, and coordination of the EHR system and administrative partners to optimize care for veterans. He has over 10 years of healthcare industry experience and has an extensive clinical and operations background, where he develops successful teams and innovative solutions to address complex healthcare challenges. In his current role, he leverages his understanding of clinical workflows and tech capabilities to support telehealth programs, system designs, workforce development, and EHR modernization. Before that, Jeff was the lead clinical applications coordinator at the VA Greater Los Angeles. So join me in welcoming Dr. Jeffrey Wilson. Dr. Darren Johnson and I have, Dr. Darren Johnson has actually been one of my greatest encouragers with organizing this organization to date, and very privileged that he's here today because he was actually one of the first people that I reached out to as a P1 student. Dr. Darren Johnson has been a clinical informatics pharmacist since 2014, and in this role at City of Hope, he was a founding member of the clinical pathways team for the City of Hope enterprise, managing both the implementation for medical oncology and radiation oncology. He's responsible for the integration of pathways into the electronic health record, staging, and clinical trials. He has worked on other high priority projects, including the City of Hope's Employer Strategy Project, quality care initiatives to support QOPI, and the Value Realization Project to show ROI pathways for staging initiative data to evaluate evidence-based care delivery and timing of new therapy initiations. So join me in welcoming Dr. Darren Johnson of City of Hope. So I'm going to go ahead and actually hand it back over to Jasmine, and she's going to transition over.
Thank you. So yeah, we have a lot of amazing speakers tonight. So we're going to get to hear a little bit from each speaker about their background and what they do at their jobs right now. So we'll go ahead and start with Dr. Scott Moore.
Well, thank you, Jasmine, and thank you for the invitation to be here and talk a little bit with you. I'll tell you, so I checked my own informatics here. My resting heart rate for today was 61 beats per minute, and a few moments ago it was 107. And so public speaking, although I've delivered dozens of lectures in this room, it never gets any easier. But I think the key point I was making is that our patients do this kind of stuff too all the time. They don't know exactly how it relates to their health. I don't know if this really affects my health or not. It could help me overcome some obstacle, or it could be giving me cardiovascular disease. I don't know. But eventually I hope that this field of informatics helps us make sense of these observations that we make. And until that, it's just data and observations and a case study. So my background is in research and mainly focused a little bit more on clinical research design, and with a focus on real world research design, so pragmatic trials. In the world of pharmacogenomics, it's these kind of I guess observations or allele frequencies that we see are small, and then the effect could be large, but you need thousands and possibly tens of thousands, millions of patients to help determine if that means anything clinically, if we should make any changes to our practice, because the changes that we make are pretty resource intensive also. So a lot of my research has been just describing barriers and challenges so far to this date, but that's really important, and especially for a new field, that is the starting point. So as you all begin trying to make your way and trying to educate others of the importance of digital health, don't be discouraged if basically you just end up describing the pitfalls. That's what pharmacogenomics might be a little bit ahead of this digital health as far as a buzzword, but it's still fairly new. And I think my perspective tonight, I'm not an informatics pharmacist necessarily, I'm a clinician. I practice at LA County, where, for the most part, county or state-run or public-run services may be the last to introduce these types of advances that cost a whole lot of money, right? So maybe people that can make it cost-effective or talk about a return on investment should be, at the forefront of describing why digital health is important. It's a lot easier, and I've found just here at USC, I've found success more with USC Keck, because the cost isn't so much an obstacle, and those patients have some money and they're willing to pay for this digital health, which may or may not help them at all. But if you're going to make it a system-wide change, it does need to include places like LA County as well. I'll tell you, one other thing that hopefully I can kind of share my perspective tonight would be the importance of clinical decision support. So it's a minute part of informatics, but the barriers that I've run into and you know, the big piece that's maybe missing from our room and our panel are physicians and nursing colleagues as well. Because when we talk about doing this, you know, one, you know, I left the patient out because they're learning this a little bit quicker than we are for the most part. They don't know what to do with it, and neither do we, but they at least sometimes know what's out there, and they're seeing commercials and they're wondering, how do I use this? So the patients will kind of drive some of the need, but your physician and nursing partners need to be able to make use of this data or report it or enter it into an electronic health record for us to evaluate along with their drugs. So yeah, my first project with CYP2/6 and opioids, the biggest problem was that we were reporting everything in a PDF document. And so it was this, you know, nothing could be triggered by it. I think there, you know, you want discrete variables is maybe the word, and I'll let my colleagues describe that better. But, you know, that's when we kind of troubleshot what went wrong, why weren't our recommendations accepted or make an intervention. It was because they weren't aware until we told them later. And they're like, oh, I wasn't sure what that meant. But if I had something to guide me and say, hey, this pops up like their renal function is below 30 and now you need to adjust the dose. If something with their digital health record, like a pharmacogenomic marker, would also just give me that message, tell me what to do, then, and maybe a link of where that evidence is, then I would be a lot more likely to do it. And that's probably my perspective for the night. So thank you.
Thank you so much, Dr. Mosley. So we'll go ahead and go to Dr. Benjamin Ardell. So I'll pull up your.
All right. Can you guys hear me? And let me know if I go too long because I can probably talk about my slides for a while. Yeah. All right. So my name is Ben Iredell. I'm the pharmacy informatics manager at Cedars-Sinai Medical Center over in Beverly Hills. And I just wanted to kind of give an overview of what my team does, what our role is within the hospital and the pharmacy department. We're a very large hospital and department. So I'll just kind of give an overview here. On the left side, you'll see our pharmacy department. We have, we're licensed for 886 beds, although our census has been over that for a number of years now. We have 90 operating rooms on our campus. We have oncology and non-oncology outpatient infusion. We have 25 licensed clinics and 2 retail pharmacies. Those are kind of all housed within the CSMC pharmacy department. And I was telling some of my colleagues earlier, we have actually 500 people in our department, including pharmacists and pharmacy technicians. So it's a very large department. I'm part of the pharmacy informatics team. We call ourselves the MUST team, which stands for Medication Use Systems and Technology. And I'm the manager over that team. I also included pharmacy leadership and frontline staff here because they are our 2 primary customers, I would say, for our team whenever we get requests for changes to the systems and we have to address those. In the middle there, I put our other Cedars-Sinai institutions because we are all integrated within the same Epic instance. And so we do work with them and have to collaborate with them whenever a change is needed. Marina Del Rey Hospital, they're a hospital with 133 beds. Huntington Hospital just joined our Epic instance last week. They have 619 beds. And then we also have the Cedars-Sinai Medical Delivery Network, which is a couple hundred clinics all around the LA area. If you see like Cedars-Sinai locations in the Valley and in Long Beach area, those are all kind of clinics part of the Cedars-Sinai Medical Delivery Network, but are not necessarily part of the medical center. And then on the right, we have our EIS department. It stands for Enterprise Information Services. And that's kind of like IT for our health system. They're the team that brings everything together. They're the team that makes the changes to Epic whenever we have a request. You guys know what I'm saying when I say Epic? Epic is our electronic medical health record. The two teams that, or one of the teams that we interact with the most is what we call the Epic Willow Beacon team. Willow is Epic's application for pharmacy, and all the workflows relating to verifying medications, dispensing medications, stuff like that is called Willow. And then Beacon is the outpatient oncology module. So that team is responding to requests from all the different sites, not just our hospital. And of course, there's a lot of other Epic teams as well that we have to collaborate with. So I'll just dig a little bit more into my team specifically. So you can see the middle graphic is visualization of the MUST team. The executive director is over me. I'm the manager. We have 3 program coordinator pharmacists. So these are kind of like your general informatics pharmacists. They're full-time. They do 4 days on site, 1 day at home per week. They're very knowledgeable in our Epic build, and they coordinate requests from leadership and from the frontline staff and from nursing, and all the tickets to change Epic kind of go through them. I also have 3 automation technicians on my team. They troubleshoot all the Pyxis equipment. We have over 250 Pyxis machines on campus, and so they're always breaking down. And we have, that includes Pyxis machines in the ORs. We call them anesthesia workstations. And then we have our data analyst arm of the MUST team. So we have 2 pharmacists and 1 technician data analyst. And we mostly work on data visualization and capturing data from Epic, from Pyxis, from Omnicell, for our carousels, from McKesson, our wholesaler, integrating that, melding them together and responding and publishing mostly dashboards using Tableau, so they can visualize for pharmacy leaders and for frontline staff as well. On the right, I kind of give a general oversight of responsibilities of our team, where we serve as the liaison between the pharmacy department and EIS. As I mentioned, we do all of the tickets submission and validation, which means making sure it looks good in the test system before it gets migrated to prod or production. We are responsible for the entire Pyxis system, building new medications, access, training staff, troubleshooting. We have a pharmacy inventory system, which we use Omnicell for, and we're responsible for the same things there. We have 7 inpatient pharmacies, and 7 of them are on perpetual inventory, meaning all the inventory in those pharmacy locations, we can look on the server and see exactly how much of each medication we have on the shelf. There are some pharmacies that are still not perpetual. We want to get all pharmacies on perpetual, so for drug shortage reasons, we can see where the medication is at any given time and the quantities. As I mentioned, we support data analytics needs for the pharmacy department. And there's a bunch of other pharmacy automation that we oversee as well, including the Swisslog cart fill robot, the infusion pump library, adding and removing and managing the entries there. We have a TPN compounder and other systems as well. And I just wanted to go over some of our active projects that my team is working on. We never really had a working acuity score in Epic. A lot of hospitals are utilizing a score which will tell you exactly how sick the patient is, so you know which patients you want to prioritize when you're an inpatient pharmacist. So we're working on that, hopefully to get something live by next year for the pharmacists to use. Of course, the pharmacists are responsible for all the patients on their unit, but this will help them quickly see which patient they need to spend the most time on. We're always working on new COVID-19 therapeutics updates. Over the past 3 years, the vaccines come and go, different bivalent variants and monoclonal antibodies. So that's always a constant update we need to do. I mentioned Huntington Hospital went live on our Epic instance. HANA is a data aggregation program that we're trying to utilize more because Cedars has a license for it. What it does, it's a kind of database tool that can aggregate and calculate data a lot more efficiently before we publish it into a Tableau dashboard. Infusion pump market evaluation, we use BD Alaris pumps as our primary smart pump at Cedars, but we are taking a step back and making sure that we do a reassessment of the market to make sure we're using the right pump. We are replacing almost all of our Pyxis hardware next year because they're very old and we're overdue for that. So that's going to be a huge project for my team. Upgrading servers to the latest Microsoft server operating system takes a lot of work. That's going to happen next year. And lastly, I wanted to mention that we're starting back up an informatics residency. We're trying to recruit for someone next summer. So spread the word if you know anyone interested. We're going to be doing a 2-year residency. We've done this a few years ago, but we haven't done it in a while. And please let me know, or you can get my contact information if you know anyone interested in that. I think that's my last slide.
Thank you so much, Dr. Adele. So then we'll go ahead and go to Dr. Adrian Meadows.
Good evening. My name is Adrian Meadow. I'm a informatics pharmacist specialist at Children's Hospital Los Angeles. And I'm just so happy to be here with all of you energetic people. So I just click right. Okay, and this is a drone bird's eye view of our campus. It's pretty big. I wanted to share with you. Oh, there we go. I wanted to explain that some informatics pharmacists report to the informatics services department, and some informatics pharmacists report to a pharmacy department that across the country. That's the way it is. There's a couple of ways you can do it. So I'm one of 2 informatics pharmacists that report to the pharmacy department, but we also at CHLA have a couple of pharmacists that report to information services department. And what I primarily focus on is the electronic medical record of the EMR. And that's as is relative to the medication use process, along with elements of the formulary alignment. And I'm going to just show you, just remind you what the medication use process is. And as an informatics pharmacist, you would probably touch on each one of these areas. So it's a cycle. There's prescribing, order verification, preparation and dispensing, administration of the drug, monitoring, and purchasing inventory management. So it's just a continuous cycle, and you would be involved in, I am involved in all parts of that. I also wanted to share with you that there's different staffing models for informatics pharmacists. As Dr. Erdel mentioned, at his facility, they do 10% staffing and 90% informatics. For my contract, I do 80% informatics and 20% staff pharmacists. And I did want to kind of go over the pros and cons of that. So the pro of staffing, there's many. It's important that you maintain familiarity with the workflow, because the more you know what people are going through in their workflow, the better design you can have. Another positive about staffing is you have a little bit, you maintain that intimate knowledge of the pharmaceutics, and you're touching the drugs. And it also kind of provides some street cred with my coworkers. It's kind of like when I'm configuring and I'm building what they're going to be using, I have to use it myself. And one person puts it like, you have to eat your own dog food. Is it going to work or not? Now, the cons to staffing is that there's less time to work on projects and configuration because there's always something to do. And it is also very hard to maintain proficiency in 2 different realms. I wanted to share with you kind of a day in my life, and it could be any one of these things. It's a lot of things. So testing, I think somebody mentioned, I think you mentioned doing testing, right? It's so important that, or maybe it was you, it's so important that when you configure something, you have to test. Now, it's not my favorite part. I really don't like it. In fact, I had to test something today. It's not fun, but you have to do it. I also do training. I'm responsible sometimes for developing the content for that training. And sometimes I have to deliver the training on different workflows and functionality of the system. It's really fun to be put on projects. One of the big projects that I was on was the barcode scanning project, implementing that. Also configuring clinical decision support. Some of the things you'd be, I get requests, service requests to configure things, to build queries, to pull back the data. Also, one thing that I see myself as is kind of the translator. I speak pharmacy, pharmacology, and I also speak a little technology. So I'm the middle person, and I can explain to some more technical people what we need from pharmacy. I support the support desk. One of my favorite things is data mining. I love, love, love data mining. I don't get to do as much of it as I would like, but that's my favorite thing. I also do a lot of documentation, and that's really important as an informatics pharmacist, because you want to keep a record of why you made a decision. Why did you turn right instead of left? 5 years later, you want to understand why you built something the way you did. A lot of troubleshooting, a lot of meetings, and then kind of overarching a lot of it is design. So you design, and you have to be a good designer. And to that point, I want to make a real important point here that a good design makes it easy to do the right thing. This is an example of a horrible, awful design. But when you're designing in the electronic medical record, these 11 words you have to keep in your mind, or when you're designing any system, not just the EMR. A good design makes it easy to do the right thing. Okay, I wanted to share this slide. This is 21 different programs, software that our pharmacists have to, and our pharmacy staff have to interact with. And so I do touch a lot of that. A lot of different systems that you'd be touching. These are just some hardware things we have. A lot of places have it. The one down in the corner here, this is our newest delivery robot. I think you guys have that. The Moxie. Ours is going to go live in December. And then I want to stress this. This is you, as you're training as a pharmacist and as you're working as an informatics pharmacist, you will always see things through pharmacist colored glasses. And that is one of the main values that you bring to informatics, to the whole team of informatics, is that you will see things as a pharmacist that no one else will on that informatics team. So you see things through pharmacist colored glasses. And I think this is my last slide. I just wanted to have a call out to our great Children's Hospital interns. So thank you very much.
Thank you so much, Dr. Meadow. Oops. So we'll go ahead and go on to Dr. Jeffrey Bolson.
Hey everyone. Sorry, I don't have slides, so you're gonna have to stare at my, I don't know, ugly mug for 5 minutes. I didn't go to USC, but I had a lecture hall that looked just like this, and it's bringing back. I'd be lying if I said fuzzy memories. You know, not that fuzzy, but anyway, thank you once again for the invite and for having all of us here. I hope you guys are appreciating the fact that informatics means different things to different people, right? We heard informatics could mean something related to pharmacogenomics. It could mean something related to building out the EMR. We heard about, data mining and translating. And so, who's telling the truth and who, informatics is all of these things really. And again, and I bring this up because the way, we all get into informatics is different. I didn't know about informatics when I was a student, or even when I was a resident. I thought, these people just sit in front of a computer all day and it just sounds miserable. I don't want any part of that. I got into informatics because I liked problem solving, and I thought, I like workflow. I like thinking about how does, a medication get from the pharmacy to the nurse to the patient? How does a referral come from a PCP to a optometrist to a technician, or vice versa? And this types of, process and systems thinking that's what drew me into informatics. This gave me an outlet, an opportunity to pursue these types of interests. So what does that mean? I mean, what I'm driving at is technology, and technology being the electronic health record, or dispensing cabinets, automation systems, or data and reports. These are all tools that ultimately, the end goal is to improve our health systems, to improve and optimize the patient care, patient delivery systems. So that sounds pretty generic, and you're wondering, well, what does that really mean? I was wondering the same. So I'll give you, again, I can speak to my world a little bit. I can't speak to all of informatics. I work at the VA. The VA is cut into 23, they have acronyms for everything. They call it VISN. So let's call it, VISN is a network. So 23 networks, and each network encompasses 6 to 8 facilities. All right. So I'm at one of these networks, and I'm responsible for supporting 8 different facilities. I'm not the only pharmacist, I'm not the only informaticist on the team. There are informatics teams at each facility, but I'm helping provide leadership and guidance to all the different facilities, looking for opportunities to standardize, to identify best practices, and to have the facilities work in a more cohesive manner. So say, for example, this organization is digital health and informatics. Well, digital health and telehealth is, it's been around for a while, but especially, with COVID, it's really accelerated. It's come into the forefront. And so we have a need. We have a need where we have providers, say, in San Francisco, providing care for patients in Reno or Hawaii, or we have people in Palo Alto taking care of folks in Manila in the Philippines. And so we need to develop workflows. It's not just a technology question, it's a clinical workflow question. How do we get a referral from any town USA to San Francisco? How does that signal go to a technician who's going to take a photo, who's going to send something to a optometrist, who's going to then send it to somewhere else? And how does it come back full circle to the patient? How does the patient get the results? And so a lot of what I do is this type of workflow, optimization and design. The people who, my customers, if you will, sometimes they ask, a technical question like, how do I get this pop-up to appear? But usually the question is, how do I get the provider to order the right medication? Or how do I take all the different, there's so many pop-ups, and people are just like powering through and not paying attention. How do we focus in on the really, the most important ones? And so as Dr. Mehta was saying, a lot of my role is translating what's important clinically, not just as a pharmacist, but, just from a healthcare perspective. But of course, I'm going to steal your phrase, the pharmacy goggles. I do wear those as well. But so I'm translating between, what is the clinical need? What are the technical capabilities? What can the tech gurus build? And there's a lot of kind of back and forth. You can have a cool product, but it makes no sense to an end user, to a clinical user. You're not going to have adoption. Right. So, it can be a great product, but if the doctor has to click through 8 different windows to get back to where they were, not so efficient. So what I'm driving at, once again, is that informatics for me is workflow, is optimizing processes, is taking, speaking a little bit of clinical, speaking a little bit of technology, understanding what's possible, but, not getting lost in the weeds of the technology, but using it to solve real world, clinical problems. So yeah, so that's kind of it in a nutshell. I also will say one more thing, for a pharmacist who's working in informatics, you may report to a pharmacy department, you may report to, a different, I report to the chief health informatics officer who's under a different umbrella. And so where it kind of is coming full circle is that, for me at least, is, I originally thought that these are people who just sit in a room and, stare at the computer. But in order to be successful in informatics, you really need to enjoy working with people and talking to people, because for me to do what I do, I have to work with all kinds of different partners to see what they see, to understand what they're doing, to talk with them, to interface with so many different stakeholders. And so I think my pitch to y'all tonight is, if you like solving problems, you like working, collaborating, working with in teams, then this is definitely an interesting opportunity. And I hope we can answer some questions and continue to raise the interest. Okay.
Thank you, Dr. Balsam. So we'll go ahead and go to Dr. Darren Johnson.
Good evening, everyone. As many times as I've spoken, I've never been the last speaker. So the last speaker always has to do something different, right? Say something funny. So one of the things that I wanted to start with is, Tiana, that seat I used to sit in every day, not just 1 year, but 3 years. So you've got to be one of the smartest students in here. And it's so nice to hear my name pronounced correctly, because usually when people look at my name, it's like Daron. And that's why I say, just call me DJ. That works too. So anyway, my name is Darren Johnson. I'm a clinical informatics pharmacist at the City of Hope, and I do want to keep us on time. So earlier I was like, I get extra time. I can talk about City of Hope a little bit, because in all honesty, they spoke about their organization so eloquently. And I'm like, oh my gosh, I didn't even put in a slide with the City of Hope. How did I forget that? This overview slide in the history, I was going to quickly just mention a few things, but I do want to keep us on time. So I'm going to do this quickly, because earlier today, I tried to do this in 5 minutes. No way. No way. I think I was on 0.3 and when the 5-minute mark hit, and I'm like, you're going to have to figure this out and speed this up. All right, let's try it. So City of Hope is about a 236 bed hospital located in Duarte, started back in the early 1900s. And the nice thing about my team is we are comprised of 2 pharmacists now and 3 nurses, and we report to the CMIO. Recently, we joined with another team, our adoption specialists, who specifically work at the elbow with our physicians. And there's about, I want to say 10 of those. So our team is about 15 people. So it's pretty large now, and we provide a lot of support for the hospital. And we need to do this because City of Hope is growing very rapidly. When I started in 2016, I think we had 8 satellites. Now we have 38 satellites, and we actually have locations in 3 different states now, Phoenix, Arizona, Chicago, Illinois, and Atlanta, Georgia. So growing very rapidly, and I think my team is going to continue to grow as we have. So just a quick little bit about the history. I'm going to try to talk a little bit about clinical pathways, just out of curiosity, and I know the people online can't raise your hand, but how many people in the room have actually heard of clinical pathways before? Wow. Okay. So I can't fly over that too fast. I'm going to have to spend a little bit of time explaining what that is. And I really do want to spend a little bit of maybe 1, maybe 2 minutes talking about the pharmacogenomics work that I do as well. So jumping right in, And I'll give you a heads up right now, my slides are really busy. Don't try to read them. Just try to listen to some of the things I'm going to highlight in general. So basically, when I try to explain clinical pathways like to my family, because they have never heard of it either, when a patient comes in to see a physician, they work the patient up, and at the end of the process, they give them a treatment. Well, a patient in California that has stage 3 breast cancer and these clinical features gets treatment A. Well, if they're in Illinois and they see a physician, same stage, same clinical presentation, you would think would get the same treatment, but that physician decides to give them treatment B. Why is that? So clinical pathways were created as a clinical decision support tool. Basically, it's a computer program that once the right information is put in, it recommends a treatment for that particular patient. And these treatments are evidence-based, and there's 3 criteria that they try to go by: efficacy, toxicity, and cost. So obviously you want the efficacy to be high, the toxicity to be low, and the cost to be low. So it's an effort to streamline treatments so that patients across the country are getting these 3 factors all the time as they're being treated. So I'm going to go to my next slide. This is just a quick look at the electronic health record that we use Epic, the same as at Cedars. This is a test patient, so there's no PHI in here, except I wanted to show this slide just because if I can move the mouse, there's this one little button that I spent probably 2 years working on getting added. And you probably can't see it, but it's the Select Plan with VIA button. So VIA Oncology was the original name. They were bought out by Elsevier about 2018, and now it's called Elsevier Clinical Path. So basically, what that button allows the provider to do is launch the application within the EHR. And that's really important because when we first went live with the clinical path, it was a separate system. So they would be in Epic working up the patient. Oh, wait, I've got to open up another browser, click, type in the URL or hit a button and launch it. And it would be separate. Now, with the advent of this button, it launches within Epic. So it's much more streamlined. So just to highlight a few of the key things that I've been able to do while implementing the clinical pathway system is, so the first thing you can see there, it launches within Epic, which is amazing. And providers are able to navigate pathways. Now it's called Clinical Path now instead of VIA. And the physician and patient information is transferred automatically. So those 3 things were all put in place with the use of that button. The other thing that it's really hard to show and explain in a slide, but basically when the navigation is completed and that treatment is recommended, it's actually automatically ordered in Epic. So that was the second integration piece that I was able to do. And then the third down here was the staging information. So providers really had a hard time putting in staging information in the VIA system and in Epic. Now there's a button that they can click and all the information crosses over. And as I figured, I'm out of time. So I'm going to wrap things up. But there's this really busy slide I wanted to show here. Again, don't try to read it. It's just simply showing that at the center of all this is the EHR. The clinical pathways program feeds into that. And data does flow back and forth a little bit, but not as much as I would like, working on that. But all of these other components that feed into the EHR, there's Omics, there's Encore, which is our clinical trials management system, other features from Epic, tumor board information, and then all of the data that we deal with is managed by our business intelligence team, who I work with very closely to make sure the quality of our data is as high as it can be. So the segue for this slide was actually supposed to be precision medicine. Exactly, what is that and how does it feed into what you do, Darren? Well, for me, precision medicine is simply, when you take the right patient and give them the right drug, you really want to make sure they get the right dose. And so what that led me to was back in 2018, I gave a talk at City of Hope on pharmacogenomics. And after I was finished, one of the physicians said, Darren, you should really work on getting that implemented here at City of Hope. So fast forward 4 years since then, I was able to just this year, I completed accrual on a clinical trial study, our IRB 21233. Let's see if I can say this without mispronouncing anything. So utilizing pharmacogenomic genetic test results to determine the optimal starting dose of tacrolimus for GVHD prophylaxis of patients undergoing allogeneic hematopoietic stem cell transplantation. Okay, I'm not going to do that 3 times fast. Bottom line, simple version is all transplant patients receive immunosuppressives. One of those is typically tacrolimus. Well, tacrolimus is metabolized by CYP3A5, and people are generally either normal, intermediate, or poor metabolizers. Those first 2 categories, the normal and intermediates, if you're a carrier of the gene, you actually should be getting twice the starting dose of tacrolimus. What that means is you would get to a therapeutic level faster and with fewer dose modifications. Both of those things are extremely important for the patient in terms of cost and just their well-being. So if there's questions about that, I can probably jump into that as we do the panel discussion, but I just wanted to thank you for your time and thank you for having me.
Thank you so much. So we're going to go ahead and move into our panel session. One second. All right, so I just want to introduce Catherine Perkins, who's Vice President of DHI, and she'll be co-moderating with me.
Hello, everyone. Thank you guys all for coming out tonight. So we're going to jump into our panel session. And so I'm going to start us off with our first question. And so I know you guys have all just heard some of the amazing things that you're able to do with pharmacy informatics, but I'm going to ask each of our panelists to just give their brief Thanksgiving dinner when your niece or nephew asks you, what do you do? What is pharmacy informatics? And so I'm going to start us off with Dr. Adrienne Meadow.
I have kind of a more textbook definition from American Society of Health System Pharmacists. This was their statement on the role of pharmacists in informatics. What is pharmacy informatics? The use and integration of data, information, knowledge, technology, and automation in the medication use process for the purpose of improving health outcomes. But I actually like Dr. Jeff's.
My turn? Okay, sorry. I guess what is pharmacy informatics? I think anyone can sit there and build a system, whether it's electronic health record or ADC server with inventory build, medication build. But I think it really takes a pharmacist's clinical knowledge behind the build to really validate that this is safe, the safest way to build this medication. I think a couple of the panelists said it really well. Like, you have to look through it through a pharmacist's lens, and things that's really true. Things stick out from all of your knowledge throughout pharmacy school, before pharmacy school, postgraduate training. If you do that, it all comes back to you, and things will stick out, and you trust your gut. And I think that's what the pharmacist brings to informatics.
So my, Thanksgiving kind of speak on it would really be kind of like the precision medicine definition that, a pharmacist with this kind of training would help someone get the right drug and the right dose, the right amount of time, based on your individual characteristics. It was like one of my, my son or daughter or my nephews or someone would be like, okay, how you're different than even your brother, you may have some differences that we would pick something to make you feel better versus them. So that's as simple as it would get at Thanksgiving.
You guys are all explaining this to your nieces and nephews. I still can't explain to my wife what I do. So it's, I spoke about, I spoke quite a bit about, leveraging technology for clinical purposes. And, on the other hand, there's also, data. Everyone wants data. Everyone has data. There's so much data now. And, there's literally devices now that record, everything about the wearer, how blood pressure, all the vital signs. But too much data it's actually overwhelming. And, a big thing of what we do, I think, as clinical informaticists, pharmacy informaticists, is taking, isolating, the signal. I didn't coin these words, but isolating the signal from the noise. So finding what's important, all these data bits that are floating around, taking, identifying what's truly important and harnessing that into something that's usable. So again, if there are 15 pop-ups and they're equally important, well, none of them is going to be important. No one's going to look at anything. So, a big thing again is, leveraging technology, but, using also that clinical background to help identify what is, truly the most meaningful and kind of focusing our attention span, our energies in that way. So I think, I think that's definitely a big piece to this.
So I can't actually believe it's next Thursday already. So next Thursday, I actually anticipate probably having to sit down with someone I haven't seen in a while and explain to them what I do. And usually, as long as I've been an informatics pharmacist, the way I've been able to make it even make sense to me is, well, there's the clinical side and there's the information technology side. So you've got doctors, nurses, pharmacists on one side that deal with all this clinical information. The information technology or IT people deal with all the technical information. Well, sometimes, more often than not, the two sides have trouble talking to each other. It's too clinical or it's too technical. Well, what we do is we kind of go in between. We have the clinical knowledge and we also have the technical knowledge. So we're able to speak both languages and help both sides understand what the other side really needs. And usually when I use those terms, just in terms of talking about it as languages and can understand the other side and being able to translate both, most of the time, the people I'm talking to in my family can understand that and it makes sense to them. So it's a little more involved in that, but that's generally how I think of it. As the informaticist is the go-between between the clinical side and the tech side.
Thank you all so much. I know this is your practice round for Thanksgiving. So now you've already prepared what you're going to say for when you have to have that conversation next week. So now we're going to jump back over to Dr. Benjamin Iredell. And I'm going to ask you, what is one of the biggest challenges that you face as an informatics pharmacist?
I think one of the biggest challenges that me and my team face are balancing thoroughness with ability to complete everything that we need to do. And so what I mean is we have all of this knowledge on all the interactions between all the different systems and teams and staff throughout the hospital, whether it's the nurses or the anesthesiologists, the physicians, and the pharmacy staff. So when we get a request to come across in our queue, right away we can start to think about, okay, this is the checklist that we need to do. We need to ask this group if it's okay, ask this group if it's okay, get P&T approval, evaluate for safety, evaluate the actual product. Is the product too big to fit in the Pyxis machine? Like there's all these things that we have to think about. But there's so many requests that come through. You can't do every single thing for every request. So it's about balancing how thorough do we want to evaluate this? What's the risk of this going through and something happening? If it's something like a fentanyl infusion and there's a request to change concentrations, we're going to be administering this concentration drip, and then starting next week we want to start administering this concentration. So that's a really risky change to make because you have to update the pumps. The pumps need to know what the concentration of the bag is. If the pumps aren't updated, the patient could get an overdose, right? And then if we have both concentrations out there on different units and Epic is only one order, then that could be an error too. So it's about balancing how far do we want to take this request? Do we want to look at all the data behind it and do a complete analysis, or should we put that on the back burner, put a Band-Aid now and move on because we have a lot? So that's kind of like where we're struggling with a lot.
Great. Thank you so much for answering that. So my next question goes to Dr. Balsam. So I know that you spoke about your workflow and how you used to interface with a lot of physicians and patients. So I wanted to ask what you love the most about being an informaticist and also how it differs from what you did previously.
It's a great question. Having come from acute care, when I first went into informatics, it was a very big change. I was used to a patient is, crashing in front of me, and I need to make decisions that are going to help the patient in front of me right now, or in the next hour, or 4 hours. And moving into a project-based role in informatics, the scope is wider and the project timeline is longer. So what I do in the next 10 minutes may not be that impactful, but trying to make this sound really sexy, if I build this button, or if I build this note template that accomplishes a certain goal, it has the potential to impact hundreds of users, thousands of patients. If I'm able to get the right message at the right time because of this project that I'm working on, my penetration ultimately may be, I'm not helping that patient in the immediate moment, but I have the ability to to have a really broad impact. And so that's something that honestly, it took a while. I trained clinically, and I was used to taking care of individual patients, or maybe in outpatient, it's not as time sensitive, but still it's kind of like one at a time, quicker. The turnover between projects is quicker. And so and again, that's honestly not for everybody, but for someone like me who likes projects, who likes big problems, I think this was a great opportunity to kind of do this type of thing, where it's more of the long game, right? Where I'm thinking, weeks and months down the line, what type of changes can I affect? So I would say, yeah.
Thank you so much. All right, so our next question is for Dr. Adrienne Meadow. And so we really want to know, as students, what tools do we need to be successful in this niche of informatics? And what are some things that students can do to prepare while we're in pharmacy school?
I love this question, both these questions. So I kind of want to turn it a little bit, because the question was what tools? So really the software that you're going to be working with is the tool. So you won't know what that is until you get on the job. And so once you get that software, you will have to learn that tool, because software is just a tool to help you do your job. What I really want to address is what attributes make you successful. And I really thought long and hard on this. And we have a pharmacist that is an informatics pharmacist. And in my experience, I've been doing this for 18 years, and she is one of the best informatics pharmacists I've ever met. And she never worked in pediatrics, and she works at Children's Hospital. She wasn't a hospital pharmacist. And so I asked her, why are you so successful? So I'm going to start with her answer, and then I'm going to kind of expound. She told me that it's because you need the ability to say that you don't know, and then take the time to devote looking for the answer. So it's important that you acknowledge that you don't know, but really dig in, because the more you dig in, of course, you're going to learn more things. So that I do think that's what makes her so successful. Other attributes, attention to detail. And what the difference here is, yes, as a pharmacist, when you are processing, filling a prescription or an order for a patient, it impacts that patient. But when you're designing workflows and affecting the electronic medical record, you are impacting just so many patients at one time. One little configuration error impacts a lot of people. So attention to detail is very important. And then what I really like is, what I really think is beneficial is to have a lot of curiosity and a lot of tenacity. Keep digging, keep working. And then for kind of tools, Excel, a basic knowledge of interface language, which is HL7. It helps to look at ISMP, Institute for Safe Medication Practice. I don't know if you guys have heard of that, because they tell you what has happened. And then it's like Murphy's Law, what can go wrong will go wrong. So it is important to read those ISMP newsletters. That helps you in informatics. And then also to be successful, you kind of have to keep abreast of federal and state laws and regulations. Oh, and then the second question. Okay. How can students prepare while in pharmacy school? The better pharmacist you are, the better informatics pharmacist you're going to be. So study your tush off. Just study, study, study while you're in pharmacy school and pass those boards. Take an intern position. When I went to pharmacy school, you had to be an intern. Now I think you don't have to be an intern, but I think it is important because that's when you get exposed to workflows. And like everybody was saying, it's all about the workflow. How do you help the workflow? And the third thing is try and get a taste of informatics during an API if you can. I look at the fourth year as kind of like you're at a buffet, a banquet buffet, and there's all this food and you want to taste all the things and see what tastes good, but try and taste as much as you can during your API year. That's what
Thank you so much for the advice, Dr. Meadow. So my next question is directed towards Dr. Mosley and Dr. Johnson. So it seems like informatics pharmacists play a huge role in precision medicine alongside pharmacogenomic pharmacists, which you guys touched upon a little bit. So I was wondering if you could tell us a little bit about the role of pharmacists in both informatics and genomics and how it overlaps with personalized precision medicine.
So I'm not sure how much during my little 5-minute talk I was able to address this issue up front, but basically the precision medicine for me, in terms of when I just think, what really does it come down to? It's the testing. You know, you've got to run the genetic test. So the study that I did was actually, that was the main component, was can we find patients, get the genetic test done, and get the results back in time to influence the dosing? So I kind of have to explain that a little bit, how the workflow was. So we would consent a patient. We would get a blood sample when they would come in for their labs, send that sample off to the labs. Typically, it would take about 2 weeks to get the results back. And we've basically determined that most patients, when they start a transplant workup, they typically will get their transplant within about 3 weeks. So the 2-week turnaround was just enough time to, get the patient, enrolled, send the sample out, get it back, and have enough time to actually be able to make have influence on that clinical decision. So for me, that's what precision medicine really gets down to, is can you get the test done and can you do something with the results to actually impact the patient? So the good news was we accrued 30 patients and all 30 of the samples were sent out and the results came back in time before the transplant started. So that initial part of the study was successful. The next phase that we're actually trying to do is to see if we can actually convince the providers to take the results and do something with them, to actually influence behavior. So there's more to come on that. So when it comes to precision medicine in terms of the pharmacist role, or at least from my perspective, there's two things that I really didn't think about that much when I started down this path. And they both in reality have to deal with money, because it's like, well, I'm a pharmacist. This is a good idea. We should do it. Well, actually what it comes down to is, great. You want to do genetic testing? Who's going to pay for it? And that was something that I wasn't thinking, about that. I could talk about that maybe if there's a question later, but the thing that actually goes along with that is important to me is access. Because if you think about it, City of Hope does about 1,000 transplants per year. What do you think the patient population looks like for those transplants? So if I tell you, if you look at CYP3A5, the normal and intermediate metabolizers, who do you think most of those patients are? You're probably right there too. So the access to getting this test done is also a huge issue that troubles me, because it's like, Darren, you're a pharmacist, but you're also an advocate. You need to get out there and figure out not only how do you get the testing paid for, but how do you increase access to the patients who actually need the testing done for them? So that's not really maybe the answer you were looking for in terms of what is the role of the pharmacist in precision medicine, but at least for me and my experience, because that's what I came here to share, that is, when it comes down to actually doing this pharmacogenomic work, there's some things that may not be obvious on the surface that you actually have to think about in terms of really trying to have an impact.
All right. Actually, those are good, great points. I don't know what else to add except, let's see, maybe where pharmacists fit. No, I think that really rings true to me, because now being in LA County, it's really tough to get buy-in from administrators. I've been looking for other roles maybe I can play there to start, maybe not at the top to begin with. I'm still providing patient care. So I think another piece that I show value with pharmacists is patient education. Enrolling them in these studies, and even with where stakeholders are a little more invested over at Keck Medicine of USC. When I enrolled patients, I spent a lot of time data mining or getting their data. I was manually curating it. I need to figure out a better way. But the rest of my time was actually interacting with the patients about how to complete their sample collection, what the test results mean to them, how they can access those results again later, because it's not built to be integrated into, we use Cerner at both these institutions. So in a sense, it's still my PDF problem. For the most part, the patients can access through this portal, through the company I use for genetic testing, but this stuff, they're not taking a complete blind leap of faith. They are in a sense, but it needs to be explained to them, just like all their other therapies, and they can understand it. It's not too scientific. It can be the Thanksgiving conversation to an extent to where they trust you as their healthcare professional and their physician. So in a sense, it kind of just comes back. It's the same answer as being that translator, but translating to what it means for the patient, why this is going to be beneficial to them. It'll get their buy-in because they end up driving their care, or they should be driving their own care.
Great, thank you so much. So before we open it up to everyone to ask any questions they have, I wanted to ask one last question to all of our panelists. So how do you foresee pharmacy informatics developing in the next 5 years? So we can start with Dr. Meadow again.
I would say that it's not just informatics pharmacy, but really just responding to general healthcare changes in the next 5 years. So informatics pharmacy will have to respond to the increase in the aging population, increase in virtual and digital services. There's going to be a lot more of that because, as you know, you feel we want Amazon-like service. So the population is going to want Amazon-like service for pharmacy as well. And then an increase in precision medicine.
Yeah, I think 5 years may be too short, but definitely in the next 10 to 20 years is more pharmacy automation. You're seeing more and more robotics being developed for the pharmacy industry. If you guys go to mid-year meeting for ASHP, you can go around the exhibit hall and see all the cool stuff that the companies are developing. I think that's the way of the future so that we can free up our staff, our pharmacy technicians, and our pharmacists to do more clinical and more patient-facing work and enhance the patient experience even more from a pharmacy perspective. Yeah.
I'll focus on pharmacogenomics again, but I think that, one thing is that pharmacogenomics, the human genome was completed in the early 2003. It's still not regular clinical practice. And there are pockets where it's becoming accepted but not implemented. And one of the major pitfalls of it was overselling it very early on and, being this paradigm shifting type of technology. And so in the next 5 years, I believe that digital health isn't going to go down that same path as what I see, that they're going to tread lightly and, communicate clearly and evidence base of what is possible and what the limitations are. So, on that Gartner's hype cycle that comes up, I think we're probably at the, kind of at a peak. I don't know if we've hit the peak yet, but when it turns, people are going to be really mad about digital health, but hopefully it won't be long. And that peak actually starts, I think it's like slope of enlightenment. So hopefully we're on that slope of enlightenment in 5 years where people are slowly, integrating it into every health system to where we can trust these algorithms without having to know what's in the black box, where it's proven itself enough and you've, and you can show where it works and where it doesn't. And people will kind of, I don't know, that's probably too lofty, but that's from an outsider's perspective.
I actually want to piggyback on that. I think, not sure again, if 5 years, maybe a little longer, but I think there's going to be a lot of attention to informatics and not just from healthcare or, pharmacy or healthcare folks, but from other people as well. You're going to have people who are interested in the financial aspect. Can we, some people might think, can we make money or can we contain costs? For example, if we're offering all these amazing new technologies and new capabilities, well, who's gonna foot the bill? Is there a way to incentivize, cost-effective treatments? And how do we again prioritize that, only the most, evidence-based or cost-effective things rise to the top? So you're going to have a lot of those folks. You're going to have attention from the legal industries who are going to, with all the different regulations between states or between, federal and state governing bodies. These are things that are already coming up in the telehealth industry and informatics. When you have, say, just to give a concrete example, you have a provider in Nevada who is trying to prescribe for narcotics in Minnesota. There's things that kind of go into that. And so, those are just examples. You're going to have a lot of attention to healthcare informatics from different stakeholders, different groups who are trying to, understand or, participate in the puzzle, so to speak. And so, I think, COVID hopefully is not forever, but technology, digital transformation, that's probably here to stay. And so, we're going to have to figure out how to wrestle with this beast, moving forward.
So generally speaking, I've never been good at this type of a question. Where do you see things in 5 years, 10 years, et cetera? It's always been one of those things where, but on this question, when I thought about it, I actually, I think I know where I would like to see us. And it's in this case. I graduated in 2008. And when I was sitting in that chair, I remember I had two options: hospital, community. That was it. I mean, we didn't talk about anything else. Nothing else was, the only other thing that maybe was out there was the little lowercase I, industry. And I mean, I think in my class was 190 students, and there might have been 2 students in my class that went down the industry route. So in the class of 2027, what I would like to see is that lowercase I become informatics. Now, just the idea of hearing that there's residencies for informatics is amazing. But in 5 years, it would be really cool if students sitting in this room had the idea that there is another option other than hospital or community. You know, just the idea that, hey, informatics, that's an option. I can consider that. And there's people I can talk to that have been doing it. Because when I first started, it just seemed like it never changed. I was always brand new. Informatics was brand new. And now I've been doing this for 8 years, almost 10, you know, and so you can come talk to me or any one of the other panelists and just, you know, it's a real field. There's real work, you know. I think earlier that question was, what's the biggest challenge? My biggest challenge was just job security. When I first started, you know, people were looking at me telling me, you're not going to have a job in 12 months. I'm like, don't tell me that. Well, now I'm on the other side of that hump. And I've been doing it for long enough time that I can tell you there is a career for you in informatics if you so choose. So in 5 years, hopefully it won't just be hospital and community, but hospital, community, and informatics.
Awesome. Thank you so much for all your answers. It's very insightful to hear from you, and I hope informatics goes down that path as well. So we have a few more minutes to open up to questions to all of our attendees. So did anyone have a question?
Professional mic carrier.
Hi, my name is Alexander. I'm a P2 student. Thank you for coming here. I have a question that I remember that I've been asking for other doctors as well when they like mention about informatics, and it's regarding about like how can informatics be applied into the community settings, because I notice and I see that everyone is talking about their hospitals, but I never see informatics in a community site. So I was wondering if any of you would like to, if they like a view or something that you might think that informatics might help in the community settings.
When you say community, like community pharmacy, like retail, okay, so you have a computer system that you use, right? And the computer system throws pop-ups at you and, you know, it says early refill or potential drug interaction. So that's a big thing right there, you know, is optimizing the decision support so that you don't get a million pop-ups, you get the important ones. You know, what does important mean? Well, you know, it could mean something different, but that's what we have to kind of arrive at is, you know, figuring out, you know, how do we focus in on the truly important stuff so that when you have a patient in front of you, you can, you know, you can quickly identify what are the, you know, top needs, what are the highest, you know, biggest ticket items, so to speak. And, you know, so that you focus on those things. Or say, you know, you could be in a retail setting or ambulatory care setting. You may have, say, I don't know, your clinic has 400 patients and you have a new service that you want to offer. You want to offer, I don't know, I'm making this up, you know, medication counseling for polypharmacy. Well, how do you identify the ones who are highest risk? You know, what do you, are you just going to count how many scripts there are? I mean, that's a start, I guess. If somebody has 20 scripts, that's, you know, something. But, you know, what are some other things that you might look at? You might look at, you know, demographics, comorbidities, if you have access to that. And so a lot of the things, you're right in that, you know, we talk about the hospital setting quite a bit, but that type of approach of looking at, identifying, opportunities, picking out the signal, amongst all these data points. I think that would translate to a lot of different settings, including community. And, in a way we can say, especially community, if you're trying to bring, say, new services to, underserved area or to a new area, you want to cure everyone and help everyone, but, you have to also work within the confines of what's realistic. And so, you're going to be using these tools, again, hopefully to prioritize and triage and, address, I guess, what has to be, first, second, and so forth. So I think there's definitely a place for informatics and all the different tools that the panelists have been talking about in multiple settings.
Hello, everybody. My name is Yasmin Saleh. I'm a P2. Firstly, I just wanted to thank all the doctors for being here today. I really appreciate it from hearing from all of you. So my question is basically regarding when speaking in terms of an informatic pharmacist and just speaking in terms of the technology that's used, would you guys say within the future are increased amount of pharmacists expected to be more integrated within informatics, since it is in like correlation to technology and the future is with technology and pharmacy? I just kind of want to hear your guys' approach on that.
I think absolutely. I think everyone, I mean, the future, I mean, just this generation growing up is growing up with smartphones. And I think just 20 years from now, almost everyone's going to be, so knowledgeable about technology and devices. And all your patients too are going to be having smartphones and doing all their own research. Nowadays, everyone can interact with their own patient chart online. You can message your doctor, you can look at your prescriptions, everything like that. So I think all pharmacists are going to have to learn everything because the patients are going to, catch up to us. And I think just working in a hospital setting, it's very good for the frontline pharmacists to know because they can point out errors instead of just thinking, oh, this is a one-off. And so they'll report it to our team and say like, okay, this is an issue with the build. And then in the community, same thing, you can point out those issues. So I think it's absolutely necessary to have an understanding of the technology.
Hi, everyone. So we have a question from Vivian here, saying that they're curious to hear more about what it's like figuring out and learning on the job to be where you are today. How do you become good at your job without much direction, being a pioneer with limited formal training? Do you spend a lot of time teaching yourself, or what are some struggles you face during the journey?
Yeah, for me, I know one of my, not really a limitation, it's just that one of the requirements to be an informatics pharmacist is computer science degree. And depending on what your training was in, it can give you benefit and it can give you might be lacking. And in my case, I just happened to be lacking because my background was programming. And the languages I was programming were a little bit archaic now. So today, the things that I need are like SQL, R, Python, et cetera. And when someone said Excel, and I think there was a little bit of a scoff, no. Excel, I would probably say it has about 5 levels of expertise, and I'm at level 1. And I work with people that are at level 5, and I'm like, there's no way you can do this in Excel. I mean, it's amazing the things you can do. So the reason I wanted to respond to this is because what I basically found was that when you are dependent on someone else to get information, it can create a barrier. So in all the different types of projects that I've worked on, I've always gotten to the point where when I needed data, I had to go to the data person. Well, I would kind of just pay attention and look over their shoulder and look at what the data person was doing and what they would give me, because sometimes the quality of what they would give me would not always be what I wanted. And then my side of the fence was basically saying, well, why don't you learn how to do it? Okay, so I learned SQL. Well, then why don't you learn how to do that? Okay, I learned R. Okay, why don't you learn how to do? So basically, you really want to be as independent as you can. So as much as you can learn on your own to be able to do it yourself, I highly, highly recommend it, because not only should you be as self-sufficient as possible, but you also want to have the ability to know what are you getting in terms of quality, because I can speak firsthand to this. I'm working on one of my projects right now with Pathways, and we're looking at our data, and there's some numbers that are off by magnitudes, like thousands, not hundreds, not tens, but thousands. Well, who's going to figure this out? Am I going to rely on them, the people giving me the bad data? No, I need to be able to figure this out sort of myself. So it really behooves me to be able to know, how do you run a simple join query in SQL? Because if somebody else is doing that, you got to remember, you get one little keystroke off and it can throw things off significantly. So I really encourage, everyone that's considering this field, figure out what it is you want to do, and then talk to people and ask them what, as the question was earlier, what kind of skill set do you need to thrive in that area? And, learn it as much as you can. Just don't stop learning.
I can add just a little bit. I just wanted to give props to the person that asked that question, because just the fact that you zoomed in to this meeting means that something is pulling and driving you, and you have that energy to go and learn on your own, because nobody pushed you to join this meeting. So you have it in you to learn it on your own. When I started, nobody knew how to do it, but something is driving you to learn, and you're just going to have to keep doing it for your lifetime.
Does anyone else have any questions?
Alrighty, thank you all so much. I want to thank everyone for coming, and we wanted to take a quick picture with the panelists. So we're so thankful that you guys were able to make it today, and thank you to all the attendees and everyone over Zoom. So we'll go ahead and end the session on Zoom, but we wanted to take a group picture if everyone can come to the front. And if you want to.